Dr. Goran Stankovic presentation. This is his point of view about the important knowledge about coronary bifurcations.
Hello, my name is Goran Stankovic, interventional cardiologist from Belgrade, Serbia, and I would like to thank the organizers of the 10th Bulgarian Bifurcation Complex Coronary Intervention course for the kind invitation to participate again as a faculty. My first task is to discuss important issues in the knowledge for coronary bifurcations, my personal point of view, and of course, I'm biased by being board member of the European Bifurcation Club. So when I discuss, I usually share the opinion from the last meeting of the European Bifurcation Club. We have come a long way. Our first meeting, as you may see, was in 2005 in Bordeaux, and the last meeting just a few months back in Brussels. This time it was hybrid event, and 60 people were attending live, and many more were attending on Zoom. So here you can see my teacher, friend, and father of the European Bifurcation Club, Yves Louvard. So our discussion about what are the new important knowledge in bifurcations will be shared between us. So I selected my personal perspective in which I would like to keep EBC ethos for bifurcation treatment, in which we should try to do procedures simple and safe. We should do our best to optimize result, limiting the number of stents, but respecting the original bifurcation anatomy. And of course, aim for very well opposed, well expanded stent and minimize the overlap. And this kind of strategy is named provisional stepwise side branch stenting, is actually gold standard approach for vast majority of bifurcations, for us including the left main. But we know that many trials in the past, since the beginning, are comparing single stent versus planned two-stent strategy in coronary bifurcations, but none of them confirmed the benefit of systematic two-stent strategy for bifurcations, since Nordic, BBC1, BBK, Cactus, and even the first study that we organized as European Bifurcation Club, EBC2, in which we compared provisional with the culotte in large true bifurcation lesions, we did not see the benefit of systematic two stents. However, if we follow our patients from the studies for longer period of time, what we see is divergence of curves and increased mortality with two-stent strategy. Very important, at the last meeting in Brussels, Professor Patrick Serruius shared in advance this very important data. It's 10-year mortality in the syntaxis and the impact of the stenting technique. And you may see Kaplan-Meier curves, red one stent technique, blue two stent technique, and you see that up to 5 years, these curves are overlapped. However, with the extended follow-up after 5 years, what we see is again divergence similar to every other prior randomized trial, with the increased mortality with two-stent strategy, more metal, higher mortality at the long-term follow-up. So that's why I selected to discuss today as important knowledge and as the highlight EBC main study, because EBC main actually tested hypothesis of provisional versus upfront two-stent strategies in left main bifurcations. Why left main is specific? Many describe left main as a different animal because of the wider angle. None of the vessels is really side branch. There is area prone to calcification and fibrosis, and there is greater need for vessel preparation. So in our perspective, we expected that two stents, maybe even more in such complex anatomy. However, ample evidence from non-randomized trials is showing worse outcomes for two-stent techniques, while randomized data, DK Crash 5 study from Shaoliang Chen, support actually two stents DK Crash in left main bifurcations. So European Bifurcation Club left main study was presented last year at EuroPCR as a late-breaking clinical trial with simultaneous publication in the European Heart Journal, and our hypothesis was to examine clinical outcomes in patients with true bifurcation left main stem lesions, randomized to stepwise layered provisional strategy in one arm versus systematic dual stent strategy in the other arm. And the primary endpoint was the composite of all-cause mortality, target lesion revascularization, and myocardial infarction at 1 year. Secondary endpoints were the components of the primary endpoint and stent thrombosis. In total, 467 patients were randomized in 31 centers in 11 countries. Stent that we used was Medtronic Onyx, and there was a CRO Circ with Marie-Claude Maurice. The reason why we selected Onyx is because of the XLV extra large vessel sizes, which are purposefully designed to treat big vessels like the left main. And 4.5 and 5.0 could be expanded up to 6 millimeters, which is optimal for the left main bifurcations with preserved radial strength and structural integrity at overexpansion. And of course, provides more stent sizing adaptability in case of the vessel tapering. Very important, technical approach details were clearly based on the European Bifurcation Club consensus documents from 2009, 2015 in both arms. Provisional, it's step-by-step layered provisional according to EBC with mandatory proximal optimization technique and kissing balloon inflation. In systematic two-stent approach, it was operator choice which two-stent strategy will be selected, allowing T, tap, culotte, or double kissing crash. It's step-by-step approach again according to EBC with very important aspect, high pressure ostial bifurcation dilatations of both limbs before mandatory kissing balloon inflation plus minus final pot. Here are the patient demographics, stepwise provisional 230 patients, systematic dual stent 237, mean age was around 70 years, predominantly male, 30% diabetes, syntax score was 23 in both groups, radial approach 70% and 2/3 done with 6 French introducer. Procedural characteristics showed that procedure duration, fluoroscopy time, and radiation dose all were significantly reduced in the stepwise provisional arm, which is very important for future application. And when we go to procedural flow, we see that POT was performed in 85% of patients in provisional, kissing in 90%, and stenting of the side branch in 22% of patients. Systematic dual stent strategy in 22% was actually half dissection and half residual stenosis. And when we look systematic two-stent strategy, it reflects European perspective and preference of culotte 50% and T or tap 33%. This is the primary endpoint. There was cumulative incidence of death MI TLR 14.7% versus 17.7%. No significant difference. Study was neutral. There was no difference in mortality, MI or stent thrombosis, and there was 6.1% TLR in provisional and 9.3% in systematic two stents, and we look for longer term follow-up. This is direct comparison in which we see that two studies had different primary endpoint. DK Crash 5 was more device-oriented with cardiac mortality, MI, and a clinically driven TLR. We had much broader criteria all-cause mortality, all MI and TLR, and this is why there is numerical difference. Of course, decay crash 5 was positive for decay crash, and EBC main was neutral. There was no difference. But if we look key outcomes, we see that in both studies, there is numerically lower mortality with provisional. When we look at the TLR, we see reflection of the practice. More two stents in decay crash had restenosis in European study, and more provisional revascularizations in Chinese study without difference in stent thrombosis. So I would like to conclude that decay crash met superiority goal despite lower than anticipated events, but the same relative treatment effect. And EBC main did not meet superiority goal in the context of lower than anticipated events and the treatment effect in the control arm, biasing results towards the neutrality between provisional and systematic two stents. These are several differences that we have to appreciate, but we have to conclude that stepwise provisional is logical, reproducible, and versatile, and in our interpretation should remain the strategy of choice for left main, because there is no need to prejudge in advance one or two stents. We simply start provisional, we add layers of complexity as necessary, and we stop when we achieve good result. End up with two stents only when it's necessary. But of course, we respect that for operators with the appropriate experience, double kissing crash is valuable option for complex left main bifurcations. However, key message is that technique itself is less important than optimal procedural application. Thank you very much for opportunity, and I will be happy to take your questions.
So thank you, Goran, for this nice presentation, very comprehensive regarding the treatment of left mains mainly. So questions, comments from the audience, from the panelists?
I have a remark to do. Hello, Goran. Nice to see you.
Hello.
Is about the flow of treatment in EBC main. You have seen that the pot was recommended, KISS was recommended, and it was performed only, pot was performed in 85 to 89%, not 100%. And the same for KISS. So maybe we can, this is maybe a subsidiary study, is to look what is the result regarding the application of the rules. We can look in the database to see if the patients that didn't receive a pot nor a KISS have a different follow-up. So this is a suggestion, an idea that, and also a remark showing that the trials are rarely perfect. And our purpose is certainly to improve the way you are treating patients, even in the trials.
Yeah, if I can answer, thank you very much. If we are trying to perform such analysis, we have some positive numerical differences, but we still cannot, with such number of total population, show clinical benefit. But if the numbers are consistently pointing in the direction pro-pot and pro-KISS, I think it's important knowledge for the application of the future consensus.
And Goran, do you think
yes,
normally,
yes, I see
normally the follow-up is scheduled for 3 years, huh?
Exactly. This is.
Do you think that we have seen the paper, the presentation by Patrice Royce? Do you think we'll have to wait 10 years for the follow-up? An easy follow-up, which is the total mortality, is a relatively easy follow-up, you know, especially in country where the mortality is public. Yeah. So.
Exactly. I fully agree with you in respect of longer the follow-up, less metal gives better outcome. And especially for the left main, the major bifurcation in the heart if you put two stents and make restriction to movement of two branches, we are expecting more impact on the flow restriction on proliferation in that area. And it was documented by Renaud Virmani group that major predictors are actually, in addition to two-stent strategy, major predictors of adverse events from pathologist perspective are malopposed struts in the area of circumflex ostium, and also absence of the removal of struts which result in fenestration of the circumflex ostium, actually proliferation on the struts across the ostium of the circ. So I believe that our suggestion has support in flow dynamic analysis, but also in pathologist analysis that we should perform routinely, POT, and probably for left main also in big circumflex to remove struts and open access into the circ.
Yoshi, do you have some comments?
Yeah, I think there is quite a difference in the patient background and the region background between the DK crash and the EBC main study, and especially the side branch region length more than 10 millimeter is a criteria for the DK crash stenting. So in the complex true bifurcation region in the left main, the target for the two stenting, the DK crash stenting. So in such a complex true bifurcation region, two stenting is favorable in such case. So side branch region length very long or complex anatomy. In such case, the two stenting, sex stenting is favorable. I totally agree with most of the left main case. The provisional approach is better, but such kind of region, the two stenting is better.
Okay, so
Yeah.
thank you, and I would give the talk about Eve.
So, as for Goran, I was asked to make my lecture, to choose. So I chose to speak about how to improve clinical outcome after distal left main stenting. The left main stenting outcome I will summarize quickly in this complex slide. The fourth trial, Noble, which is randomized trial, but we look at the PCI arm. Excel is also randomized trial. We look at PCI arm. DK Crush 5 and EBC main are randomized versus 1 versus 2 stents. So what is remarkable for EBC main is that the population is older, much older than in other trial, 71 instead of 66 in Noble. Second, diabetes rate is low in Noble, and the same for Excel in worldwide, DK Crush in China, and EBC main in Europe. The syntax score is much higher in DK Crush 5, and this is a marker of the complexity of patients treated in China that makes the comparison between EBC main and DK Crush 5 impossible. And the distal, it was the studies were dedicated to distal true bifurcation lesion in 100% in DK Crush 5 and EBC main. Regarding the endpoint, the primary endpoint, they are completely different from one study to another one. So it's very difficult to make a comparison for this endpoint. We can look at the mortality, and we can see that at 1 year we have between 2 and 4% of mortality. If you look at 3 years, we are between 7 and 8%, And if we look at 5 years, we have 12 to 13%. So we are in EBC main, we are at the time around 3 to 4%. So we can imagine that in 4 years will be high like in Noble and Excel. Left main, 1 versus 2 stent outcome. 3 trials, a sub-study of Excel comparing 1 versus 2 stent. And as said, Goran Stankovic is very clear that is here with decima stroke at 3 years, that having a single stent in the left main bifurcation is better than having 2 stents. Of course, doesn't mean that we never put 2 stents in the left main bifurcation. It means that when it's possible, it's better to do 1. And when you look at the decima stroke and revascularization at 3 years, it's exactly the same. And in fact, provisional, double stenting is predictors of both events, decima stroke at 3 years and decima stroke and revascularization. So in conclusion from this Excel, by multivariable analysis, a planned 2-stent strategy was strongly predictive of 3 years adverse outcomes. And these findings endorse a provisional stent strategy for distal left main bifurcation PCI when feasible. And this is the important word, feasible. So this is the paper of DK Crush by Dr. Chen. So I will look in a bit of detail. You have, when you look at the target lesion failure, which is the endpoint, the target vessel MI, and a cardiac death, you see during the first 30 days disadvantage for the provisional strategy. After that, if you follow during the year, these 2 curves are parallel. But when you look at stent thrombosis, where is stent thrombosis? Definite or probable stent thrombosis, bottom right. You can see that also during the first month, the stent thrombosis rate is higher in provisional stenting, and after that, up to 1 year, is not different. I am very surprised to see that during the first 30 days with stent thrombosis, if you look at the target lesion revascularization during the first 30 days, you don't have intervention. So it suggests that this stent thrombosis during the first months were not treated. So comparing the provisional strategy and the DK Crush in Excel, I think some mistakes were done. So DK Crush was done in 240 patients, in 100% of patients, and provisional stenting was applying, I would say, nearly a politic of second stenting in case of real problem. So you can see that a side branch stent was implanted in a provisional group in 47% of patients only. And a final kissing was done in 80%. When you look at the lesion in lesion in the side branch, in provisional stenting group and in DK Crush, is very different because the lesion length is, there's a mistake here. It's not a mistake. This is 16 millimeter. 16 millimeter. Personally, I know since the 90s that it's impossible to treat with a balloon only a lesion of 16 millimeter, and was more than 10 millimeter in 42.9% of lesions. So this comparison is unfair. Would have been done provisional with large use of double stenting versus DK Crush. And the last point is this. Look at the end of the curve for target lesion failure, the endpoint, and target lesion revascularization at 1 year. The angiographic follow-up was systematically scheduled at 11 months. And when you look at the time it was done, was 360 days. So this is exactly 1 year. So 1 month before the schedule control, and exactly at the time of the clinical endpoint, which is a mistake. We know that since a long time. So many people were treated in the provisional stenting strategy group on the day on the coronary angiography without any test for ischemia and without FFR in the side branch. Because my opinion is that this difference of reintervention in provisional stenting and decay crush is related to lesions in the circumflex, which are not really significant. This is an old paper showing that the influence of angiography before clinical endpoint on the treatment by Ruigruk in 1999. It was not recommended at all to perform angio before clinical endpoint. So European, the comparison between the two trials, EBC main and decay crush, is very difficult for all the regions I've cited already. EBC main, Goran has showed the result. You can see that the combined endpoint is much higher, not the same than in decay crush, because this is total mortality and not cardiac mortality. But, you know, the difference is a bit suspect, I think, compared with provisional. Remember, the lesions are not the same. And in EBC main, there is no difference between 1 versus 2 stent, even if there is a light trend for a lower endpoint in double stenting. When to choose systematic left main double stenting. So we can follow the philosophy of the bifurcation club. So, of course, in this left main bifurcation, all protection only for non-clinically relevant side branch, there is no discussion. All the circumflex are relevant. Limit the number of stents, put a single layer of, avoid overlapping, well opposed, and respect the original anatomy. So in this Medina classification, the question to put double stenting is only in these two situations, 111 and 011. So the perspective of BBC, as described by David Dildick-Smith, approach bifurcations in a stepwise manner, add layers of complexity as necessary, stop when you have a good result, and end up with 2 stents when necessary. On the contrary, in China, they try to define before the procedure, on the coronary angiography, the necessity to put a second stent. So they develop a score, which is the definition score. When you have a major factor plus 2 minor, this is complex. When you have a major 2, that's for left main, any 2 minor, a major factor and 2 minor, this is complex. So this has to receive a decay crush. This is an algorithm by Thierry Lefebvre for provisional, think provisional. When you have a low risk of side branch occlusion, you do a crossover stenting, and then you complete by a double stenting if necessary. On the contrary, when you have a risk of side branch occlusion and difficult side branch access, you can do, following the definition rule of Dr. Chen, a step or a decay crush. But you can also use a strategy which is frequently ignored, which is the inverted provisional side branch stenting. It means that you do a crossover stenting from left main to the circumflex. And after that, you can complete with inverted tap, inverted culotte. How to improve clinical outcome after distal left main stenting? We need a better stenting. That's why I was asking the question to Goran. Provisional side branch stenting strategy is relatively complex, and as you can see, many steps. And if you forget 1, 2, or 3 of them, this is not a provisional stenting strategy. One of the important points for this strategy is that when you have done your crossover stenting, you have to re-enter the side branch through the most distal cell. For mini decay crush, I limited the number of pitches here, because this is much more complex than for provisional. You need 2 times kissing and 3 times a pot. And this is an example of a kind of problem you can have. You stent the side branch with a protrusion, then you crush with the balloon in the main vessel. And you can see that here, the balloon is chosen from the distal vessel diameter, and you will see that the stent is not completely crushed. So you can re-enter here. So Dr. Chen added an additional stage at his procedure by crushing the side branch stent with a pod balloon. I mean a balloon adapted to the proximal segment. And after that, when you try to recross toward the side branch, you have the risk of crossing outside the stent close to the carena. So you have to re-enter the side branch to do the last kissing and the last pot through the most proximal cell. And you see here at the end, at the end, there is a triple layer of stent, just proximal to the side branch and lateral. This is the result. You can see here that the maximum expansion of the main stent was reached with this strut floating in the lumen. Mini culotte, also complex, especially mini inverted culotte, as I explained earlier. You have to remember that this culotte is a double provisional. So when you re-enter to the side branch first, you have to enter distally. Then when you have stented the main vessel, you want to re-enter the side branch, you want to re-enter towards the main, and you have to do that through the most distal cell. When you don't do that, you have this accumulation metal of carena. So double provisional, each time crossing close to the carena. Stent sizing is also, for me, a problem. First, you have to adapt your stent to the anatomy of the vessel with two diameters, as been explained already. You have to avoid oversizing of the distal main vessel because you are creating a new anatomy of bifurcation with the same diameter distally and proximally. And the flow in this situation was well shown years ago by Dr. Iwasaki in Japan. There is flow perturbation at the ostium, especially if you don't remain the strut and create cell closures. Well, on the right, on the contrary, if you respect the anatomy, you have a rapid flow in the side branch and keep the cell open. I suggest also to study this problem. I don't have an answer. When you are facing a very severe angle and doing inverted provisional, you need a very big stent, but also with capacity of elongation. If the capacity of elongation is not enough, then you are straightening the external curve and reducing the lumen. How to measure the size of the stent, the size of the vessel you need? So you have different ways to measure the lumen using intravascular imaging. On the left, you have a work with a phantom and measurement with OCT and IVUS. And you can see that IVUS gives you 8% more diameter than OCT. Nothing to see with media to media, just measurement. And on the right, you have comparison of measurement inside the vessel between OCT, IVUS, and QCA. And you can see that QCA is giving abnormally small diameter compared with OCT, very close to phantom, and compare, of course, to IVUS. Personally, I will explain that. So you know the phenomenon of positive remodeling. You can measure lumen to lumen on the left here, or when there is a lesion, you measure media to media. So now look at the schema at the right. When you use media to measurement, and when you have a bifurcation here, you implant a stent which is too big to reproduce the original anatomy. And I have seen personally case done by Dr. Chen with a closure of the circumflex without lesion, you know. So don't take media to media. For me, it's a factor of occlusion of the side branch. Bifurcation lesion preparation was a topic during the last meeting. I think you have to push something here. No, I will go skip this one. It's not good. So to improve the deployment of a stent in calcified lesions, the left main is frequently calcified. Scoring, cutting, this is done. They have been used. Rotational atherectomy, they are used also, but we don't have a real study. Orbital atherectomy is just coming in Europe. We don't have trial. And lithotripsy is now frequently used, but we don't have also trial showing that it changed the future of the patient. An example of lithotripsy by my friend Thierry Lefebvre, a patient that has a pneumonectomy for cancer and this left main lesion. And he was, the surgeon open to do surgery, wasn't able to graft. So the patient went down on the cath lab and have this shock wave in 3 segments. And after that, he was, as you can see, stented with inverted provisional with a good result. Other improvements that we can have during the next year, we had a session this year on it, is how to reduce double stenting or avoid it. You can do a crossover stenting and a DCB in the side branch. We are thinking of a trial on this situation. In Korea, a lady, Dr. Chin, is doing DCB only for the whole bifurcation, even left main. And in Japan, Dr. Kinoshita is doing directional atherectomy, remember Simpson, plus DCB to treat left main without stent. So I don't know, we don't have Simpson available in Europe today, but we are waiting for really trial and comparison. So my conclusion is how to improve clinical outcome after distal left main stenting. You have to learn the techniques and to perform all the steps. Follow the recommendation for all evaluated technique. It's better to have to be an operator with a big volume for left main, prepare the left main bifurcation properly, and double stenting only when necessary. It was cited the factor we don't have yet a consensus of side branch lesion length to choose a systematic double stenting. It was found in DK Crush group, but in EBC main was not found. Evaluated trials, new device, and most promising for me are certainly lithotripsy and DCB. Thank you very much.
So thank you, Yves. It's an amazing presentation. Now the discussion is opened about the questions, comments, and from the panelists, do you have some comments, Goran?
Can you try?
No, I don't have anything to add because this, with my lecture on EBC main, I think completes and contemporary overview of left main PCI, putting the latest knowledge presented at the EBC meeting and introducing the concepts for lowering the amount of metal with use of drug-coated balloons for the side branch. We are working on the studies. At every meeting in the world, the first question is, can we use drug-coated balloon for the side branch? But we still don't have clinical evidence from the trial. We have small registries, but randomized trials which are available are with low number of patients recruited and negative outcomes. So we really need to collect more evidence and base decisions on the evidence, not on the perception that having drug-coated balloon improves the outcome. So this is my comment.
Yes, Nikki?
Yes, I have a question. We all know the benefit demonstrated by the imaging-guided PCI of the left main. And can you comment the rate of IVUS used in EBC main and DK crash? If my memories are correct, we have about 40%.
DK crash and 34% in the EBC main.
Yes,
yeah.
That was really strange for me. And can you
I have in front of me here Murasato, a fan of imaging. And he knows that in France, imaging outside meetings, of course, imaging is very, very low. And each time we have specialists, I'm asking them, do you have a randomized trial proving absolutely proving that using intravascular imaging is giving us better result in left main or in non-left main. You have data issued sometimes from big database, but a database is not a randomized trial. So we will be, I don't say this is not useful, to be clear. If in France we are not reimbursed for it, so we don't use it. But to be clear, we'll be reinforced to ask our government to reimburse the IVUS or OCT if we have a randomized trial. I asked a question to Gary Mills a few years ago. I think a trial is going, but I don't remember where.
Yoshi, what do you think about the imaging in the DK crash and EBC? And in Japan, it is actually almost 100% imaging guided PCI situation.
Yes, exactly. In Japan, almost 100% of the case under the imaging guidance. IVUS is 60-70% and 20 to 30% in the OCT guided. And I think imaging is necessary for especially left main bifurcation intervention because imaging is useful for deciding the stent size, the device size, and optimization of the stent expansion and less malapposition. As you know, malapposition in the left main bifurcation is associated with a fatal event, a stent thrombosis with a fatal event in the future, more than 5 years later. And OCT is also very useful. 3D OCT is very useful for assessing the guidewire recrossing point. As Eve presented as a guidewire recrossing points, a distal and DK crash stenting, the proximal site is the optimal point. 3D OCT can evaluate such kind of a precise point. We performed the follow-up OCT study after the provenance stenting and the two stenting. We often fail the kissing balloon inflation, often fails the complete opening for the side branch because of the wire crossing success rate is angio guidance is only 66%. However, 3D OCT guidance elevated success rate more than 90%. So accurate, precise positioning of the guidewire recrossing and optimal size, side branch dilation, optimal size, proximal optimization, that will lead to the complete revascularization of the natural bifurcation geometry. I think so.
Well, that was quite a comprehensive response.
Yeah, no, I agree. I've seen Yoshi many presentations by you on how to access to the most distal cell. So, yeah, I'm telling that, but we don't have a trial saying a systematic crossing from proximal and systematic distal and comparing what are the results. That's what I say. You know, if you go to a ministry to ask reimbursement for IVUS, I cannot tell them. I have a very good friend in Japan. He tell us this is much better to have imaging than no imaging. He will say, he will smile, you know, and not give the money for sure.
Okay, so we are waiting for a trial for the heart endpoints improvement with imaging. And probably even with
a trial is ongoing, but I don't remember. Goran, you remember? You know, an ongoing trial with imaging?
I'm not aware as well what is the place, but we discussed that, and the data from the Ultimate, which had 10% of patients with left main, and IVUS XPL already showed some benefit in regards of the heart events. So definitely, if we suggest and if it's possible to use imaging, of course, imaging has advantages, but we still don't have, as you said, a randomized evidence with the image guidance. We are waiting, to be honest, results from the Illumian 4 and the October for OCT. Both are powered for clinical outcome, and we really look forward to the results of OCT guidance in regards of improvement of clinical outcome. There is a strict protocol which is recommended, and I believe that if you have possibility to have image-guided procedure, whether it's OCT or IVUS, especially for the left main, I agree with Yoshi, it's strongly recommended.
So let's proceed further, and next talk, because we started with switching, Goran first, and then you will finish.
Yeah.
Hello, my name is Goran Stankovic, interventional cardiologist from Belgrade, Serbia. Thank you very much again for the kind invitation to attend Bulgarian Bifurcation Complex Coronary Intervention course. And my second topic is strategies beyond provisional. And I would like to start by saying that most of the knowledge that I will try to share in the perspective of beyond is actually the result of discussion that started in 2005, how to define provisional, what is the provisional, and what is beyond provisional. The last meeting was in Brussels as a hybrid event just a few months back, and many board members attended live. Unfortunately for me, because of the epidemiological situation, we were not able to travel. So I did not participate live, but I followed all the sessions, and I will try to summarize for you what was the decision when we described how to perform bifurcation PCI and what is the role of planned two-stent strategies, if we speak beyond provisional. First, I need to say that when we say beyond provisional, it's really not completely along with the provisional as a philosophy of stepwise stenting of bifurcations, because provisional strategy for us is starting by stenting of the main vessel, optimizing the result with POT, and then evaluating the result. If the side branch is severely compromised, tightly narrowed, or TIMI flow is less than 3, then we recommend to go stepwise, increase complexity, open the side branch, do the kissing, and then evaluate again. And the result of side branch is still not optimal. Then we proceed with the next step, which is implantation of the second stent as part of the provisional strategy. So for me, key message, strategies beyond provisional, is actually that provisional stepwise actually does not prejudge in advance which lesion really needs two-stent strategy and which lesion we start with single stent and then we add second stent if the result that is achieved after optimization of the first stent is suboptimal. So provisional is not equal to single stent strategy. Provisional is stepwise approach recommended in EBC consensus documents since 2005 up to 2021, in which we try to promote not judging in advance, but performing step-by-step stent implantation in one branch, optimizing result, and adding second stent with T, TAP, or culotte whenever it's necessary. However, if you look on geography, and if you need to define what are the lesions in which you expect in advance that you may need to finish with two stents, in 14th EBC consensus document published in 2019, we say elective two-stent strategies may be considered for important clinically relevant side branch with complex and extensive stenosis, difficult side branch access, or high risk of side branch compromise. But of course, selection of specific technique should depend on individual patient's anatomy and on the operator experience and skill. We cannot recommend one strategy in favor of some other strategy. What is the reason that we speak about diffuse extensive disease in big side branch? I will not go in depth analysis of the literature, but very relevant meta-analysis that was published in JACC Cardiovascular Interventions 2020 showed actually that there is difference, but not in all procedures, not in all bifurcations. And I kept the title that was used to promote this publication, DK Crash provides best outcomes, which is not completely correct. Actually, if you analyze in which subset of lesions two-stent strategy, specifically DK Crash, was better, it's actually only in side branches in which the lesion length was longer than 10 millimeters. And this kind of population is really not very frequent one. And if you look all the other bifurcations in which there is side branch lesion, it's true bifurcation lesion, but side branch disease is shorter than 10 millimeters, there is absolutely no difference in outcome. There is similar risk in provisional as well as in two-stent strategy. So based on this, Professor Chen nicely designed the first definition and then definition 2 study, trying to define what is really complex bifurcation. And in definition 2, it was clear that two-stent strategies in blue had lower event rate, TLR, target vessel MI, and target lesion failure compared to provisional. But what is important to analyze is complexity. Actually, side branch lesion length in definition 2 was 20 millimeters in both groups. So we know since the Benesten study, since 1994, that for such diffuse disease, stent is better than balloon. You cannot expect that with 20 millimeter long lesion in the side branch, you can just inflate balloon and leave the result in majority of cases without stent. So we need to be aware that only for patients with complex bifurcation lesions, according to definition 2 study criteria, systematic two-stent approaches were associated with significant reduction of target lesion failure compared to provisional. We went as the EBC even step beyond this, and then in the 15th consensus document that was just published last year, 2021, we say that when you plan two-stent strategy up front, this should be done in a stepwise provisional approach to the lesion, finalizing procedure using either T, TAP, or culotte technique as continuation of provisional strategy. This is just puristic to say that provisional strategy, again, is not single stent. Provisional strategy is step-by-step decision-making and adding layers of complexity when you don't achieve optimal result at previous step. Of course, we are aware and we accept the strong data coming for DK Crash, and we also put in the consensus that for operators with the appropriate experience that was required in DK Crash studies, DK Crash is valuable option for complex left main bifurcation lesions. Extensive understanding of two-stent technical steps is pivotal because adherence to the best practice, the sequences of ballooning, stenting, impacts on the efficacy of all two-stent techniques. And to summarize for you, this is European Bifurcation Club MEDS classification of the stenting techniques presented by our mentor, Yves Louvard, first time in 2008, was published in Catheterization Cardiovascular Interventions. And this is from 2018, updated MEDS classification, in which actually there are two major categories of stenting bifurcation. Category A, which is main vessel across the side branch, or something that we name provisional strategy. And the other one is S, ostial side branch stenting first, which is practically nowadays decay crush. Because SKS and V stenting is not recommended by the EBC. So what we currently have is either stenting of the main vessel first across the ostium of the side branch, which is A type of technique, or inverted A, which is intentional stenting from the proximal main vessel into the side branch, optimization with pot and kissing, and then putting second stent as inverted T, inverted tap, or inverted culotte. So this is one line of stenting, starting from the proximal main vessel. The other line is stenting from the side branch, and this is S strategy. So when we speak about plain two-stent strategy, we speak either of A or inverted A, which means T-tap culotte, or inverted T-tap culotte, or we speak about S strategy, which is stenting of the side branch first, or stenting sometimes of the distal main ostial as inverted strategy of the S. How do we make decisions? Actually, what we agreed and what we published in the EBC recommendation, we try to estimate in lesions with extensive atherosclerotic involvement of both branches, important and diffusely diseased side branch. We estimate the risk of losing the side branch after main branch stenting. And if we don't expect high risk of losing the side branch, we go main category A, we go main branch stenting across the side branch, optimization with pot, kiss, and then T, tap, and culotte stenting. However, if we expect major concern regarding the side branch loss after main branch stenting, for experienced operators for decay crush, one option is S category, which is decay crush nowadays, or nano crush. The other approach could be inverted provisional, again, stenting from the left main into the circ, optimization, and then inverted culotte, inverted elective T, inverted tap. So I will go really very briefly in the most important aspects of these techniques. So start with T and tap. And this is animation which I prepared with my colleague Zlatko Mehmetbegovic, which shows you tap stenting in this case, but it's actually continuation of provision. You see stenting of the left main according to LAD diameter, then pot throughout the length of the stent to achieve appropriate apposition, pull back, distal recross, opening of the struts and kiss, and then we position stent in the circumflex, deploy with uninflated balloon in the LAD, we do kissing, and then plus minus we do proximal optimization. And you see our goal is actually to cover the lateral wall of bifurcations, and as a consequence, we have this small, short, metallic neocarina with tap stenting, and we don't have neocarina with T stenting. We believe that if you are able to cross through the distal strut after pot, you are able to push some metal and scaffold the ostium of the side branch, of the circumflex in this case, and this will allow you not to protrude with the circumflex stent inside the left main stent. So this is T stenting. However, if you cross proximal instead of distally, then you don't have this positive scaffolding of the ostium of the side branch, so you need to pull back your side branch stent in order to be able to fully cover the lateral wall of bifurcation. And this is visible heart lab images in which on the left-hand side you see T stenting, no metallic neocarina in blue. On the right-hand side you see metallic neocarina, and this is the provisional tap stenting. It's very important to understand that there are favorable and unfavorable two-stand strategies. If we are able to minimally protrude, to do final kissing and position metallic neocarina in the center, what we learn from the bench testing is that we will preserve laminar flow and high shear stress area close to carina. However, if we have too long protrusion, metallic neocarina impacts on the flow dynamics, and we have this flow disturbance with low shear strength area in the carina side, and that frequently may result in adverse events. Second strategy is the culotte. Again, step by step. This is standard provisional culotte, pre-dilatation of both branches, stenting of the main branch first, the same struts as it was for TAP in the beginning, proximal optimization to open fully opposed proximal path, distal recross, opening of the struts towards the diagonal in this case, and then minimal protrusion of the side branch stent, but adequate when you do pot to oppose second stent also with minimal overlap in the distal path. Kissing with high pressure individual inflations, and the final pot to correct for the proximal edge deformation. And you see again in blue side branch with minimal overlap in the proximal part, and you see good coverage of the carina. This is again bench testing showing that if we cross distally, if we remove completely metal from the ostia, we have better flow, favorable culotte. If we leave metal, do a layer of metal in the carina side, we actually have malopposed struts at the circumflex ostium, and we have unfavorable culotte. Gabor presented at EBC double kissing culotte. The only difference is that actually after first stenting, you don't only do pot, you also do kissing, because if you don't do kissing, when you inflate balloon to open struts, you actually disconnect and you have some gap in the lateral wall of the first stent. But if you do kissing balloon inflation, then your stents are fully opposed, and the final result, as you see, with double kissing culotte is better than with single kissing. My message is you can do double kissing culotte as a provisional towards one branch, and then the same steps provisional with kissing towards the other branch. Hello, my name is Goran Stankovic, interventional cardiologist from Belgrade, Serbia. Thank you very much again for the kind invitation to attend Bulgarian Bifurcation Complex Coronary Intervention course. And my second topic.
So, hello again. Very nice overview of two-stent techniques. Goran, what is your favorite two-stent technique, personally?
Personally, I decide step by step, because at every step there is influence of the stenting technique on the local conditions. So based on what I achieve at each step, I decide what would be the next one. But the idea is to protrude minimally and to try to limit the overlap. So should be T if possible, but then you proceed. It's important to achieve optimal results. So I really believe you decide based on the reaction of the stent vessel wall interaction. If you achieve good results with minimal overlap, then you should aim for that. But if it's necessary, you can do T, TAP, or culotte. I definitely don't do decay crash, and this is the only strategy I think that is not familiar with my philosophy. So I respect people who know how to do it. I'm not against. I think it's excellent technique for experienced operator. But you know, requirements to participate in decay crash 5 require conditions of 300 PCI in the last 5 years with 25 left main PCI, in these 5 years. So if you apply it to 800 interventionists in the UK in the recent publication, only 6 interventionists in UK have requirements to participate in DK Crash 5. So 794 interventionists in UK do not meet the criteria. I believe it's a just matter of being honest. If you do it every day, if you know how to do it perfectly well, if you look live transmission from Shaoliang Chen, it's excellent. But as Yves said, there are 9 steps. You can make mistake at every of the 9 steps, and you take the risk.
Okay, so that was a very nice answer. And Yoshi, do you have some preferred two-stand technique personally?
Personally, Kuro technique is the best technique for me because we don't like the 3-layer overlap in the proximal site with the DK cross stenting. So we fear the stent thrombosis or thrombus attachment and such kind of metal overlap inside. So minimal curate is the best technique for me. And however, we recently analyzed the 3D OCT analysis. The curate technique has a risk of the full open for the main vessel stent. As you know, the sideband stent should be open in the main vessel main branch ostium. However, suboptimal guidewire recrossing leads to the suboptimal main vessel branch ostium dilation. So it's in such meaning the curate technique has a risk of the limitation of the main branch ostium expansion. So using the imaging is very important.
So back to imaging. So nobody from the experts do the recommended in the only recommended in the guidelines technique DK crash. It is very interesting. So I would like to ask Yves to give his talk about the provisional strategy.
So provisional strategy in bifurcation treatment, this is still the gold standard. So I can answer the question. I always use this strategy. My last culotte was in the 90s. And at that time, we were doing that with bare stents. And we had 40% of restenosis. And we proposed in the AHA meeting treatment of restenosis with double rotablation. So, of course, with the stent we have today, this is completely different. But as was said by Yoshi, and I showed also with images from visible art, it's very difficult to re-enter both sides close to the carena and suppress completely this metal. So, you all know this Medina classification. And it was said by Goran that today we are using mainly A or S strategy, or inverted A, inverted S. An important point came to the discussion a few years ago, maybe now 2014, I think, clinical relevance of side branches. So, fighting against excessive double stanting, or temptation of excessive double stanting for small side branches. So this is a work by Hashamovich in 2003, it's old, defining the total amount of ischemic myocardium with isotope, and looking at the superiority of medical treatment or revascularization. And he concluded that when the ischemia is more than 10% of myocardium, there is an interest of revascularization against medical treatment. And this is endorsed by European Society of Cardiology, even in the most recent 2018 version. So how to measure the ischemia? You have several methods today. You have isotope, as I said, but also you have stress echo. and you have CMR stress. So we are able to do today a revascularization of ischemia, confirmed and quantified. And you have here the equivalence done by Shaw between the three methods. So Dr. Koo in Korea tried to adapt this concept of 10% to define what is an important side branch, which need to be treated with balloon or with stent, versus a small side branch that, even if we don't need to lose it, can be protected only. So this is ischemia and myocardial mass at risk. On the left, this is the myocardium supported by a vessel. There is a relationship between the amount of myocardium, the size of the vessel, the length of the vessel, and the flow inside, of course. So it's quite easy to define what is myocardial mass at risk, depending of any vessel. On the right, it showed you that myocardial ischemia is always smaller than myocardial mass at risk. And this is related probably to collateral filling. And of course, we are unable, when we are facing a bifurcation with a lesion on the main vessel and the small vessel and the side branch, we are unable to say which amount of ischemia is depending from the side branch. So we have to find a surrogate to identify this big side branch that need more care than small ones. So it was used in two countries, Japan and in Korea, a method of myocardial segmentation with CT scan. And you can see that each vessel is perfusing each territory, well defined, can be measured. And in Korea, they produce an atlas of the side branches of supporting more than 10% of myocardium. This is not ischemia. This is 10% of myocardium supported. On the left, you see that for left main bifurcation, there is nearly 100% for the circumflex, 100% of support, more than 10%, nearly 100%. So left main is a major bifurcation. When you look at non-left main in gray, the second one, you see that for non-left main bifurcation, only 20% of the side branches are supporting more than 10% of myocardium. I mean, maybe 6% of ischemia. And you can see that among these vessels that are more frequently relevant, you have the posterolateral branch of the right, when it's dominant. You may have the second marginal, but it is relatively infrequent that diagonal is supporting more than 10%. This is for the first diagonal, around 20-25%. So only rarely these side branches are relevant. To try to define for daily usage which side branches and which diagonals are relevant, Dr. Koo proposed a score. I won't go inside this. But the score says that, for example, the left bifurcation here is relevant between, no more working, but it's relevant because this is a single diagonal, proximal, so this is relevant. The two others, they have several diagonals which are sharing the territory of diagonals and which are not relevant. And the consequence of this for him is that when it's not relevant, I will skip that. When it's not relevant, we are facing what we can call a minor bifurcation. When we put a wire in the side branch, and in case of problem, we can do a bailout ballooning or even a bailout stenting. But the purpose is not to think about the treatment of the side branch. When we have a relevant side branch, we call it a major bifurcation. And in this situation, when there is a lesion in the side branch or when there is a modification of the side branch after stenting the main vessel, you may question the treatment by balloon or stent. So you have seen that algorithm proposed by Thierry Lefebvre, through left main bifurcation lesion, think provisional. So how to decide when to do provisional, how to decide to use alternative strategies. When you have a low risk of side branch occlusion, and especially, of course, when there is no lesion in the side branch, the best is to use the provisional strategy, crossover stenting, and then, regarding what occurs, move to T-tap on culotte. When there is an high risk of occlusion or a difficult side branch access, we are thinking difficult side branch access, for example, with a stent through the main vessel stent. You have alternative techniques. The decay crush, of course, you begin with the side branch, or you use inverted provisional, stenting from the proximal main to the side branch. After that, you can complete the double stenting by going to the main distal. And much easier regarding the angle, much easier to reach with the stent. So provisional side branch stenting strategy, this is these are the words of David Dick-Smith. This is rigorous, we have this is logical, this is flexible, versatile, and it offers option to do less rather than to do more. Remember the comparison between single and double stenting in non-left main and even in left main lesion like in Excel. So an example, this is a complex lesion, I think. You know, you have a lesion of the left main, a lesion on this LED diagonal. So 2 wires, systematic 2 wires. This is stenting. And you see on the picture on the left that the stent is not completely deployed. So, and you have chosen the stent from the distal main vessel, so the side branch is still there. After that, you do a pot to open the proximal part of the stent. Will help you to exchange your wires, not outside the stent, but inside the stent. So after that, you imagine that preparing this case, I decided from the beginning to do a double stenting. So this provisional, so-called provisional, is also my strategy to do systematic double stenting. So after that, I decided, of course, to put a stent in the side branch. So I prepare, wire exchange. So wire exchange, you come from the distal bed, you rotate your wire, and you go to the side branch. This is predilatation of the side branch. This is the result after predilatation. Some of you maybe will say, okay, the result is not so bad. Why not living like this? Some ones maybe will do it. But I decided to put a stent from the beginning on a long lesion, longer than the balloon segment, to prevent restenosis. As was telling Goran, we've seen since a long time that we cannot treat very long lesions with balloon only. So a stent, a long stent, as you can see, crossed very easily, was implanted as a T. You choose T and tap, was explained already, but on the left you see very clearly projection of metal from proximal part of the stent towards the side branch. So here this is favorable for T. On the contrary, here you see projection in the distal main vessel of the carena, stented carena. So here you have to do a protrusion, tap. So after stenting as a T, double stenting equal kissing. This is mandatory. And we try to remain in the polygon of confluence. And this is the result, which was, for me, very clearly good, especially after doing FFR showing a non-significant left main. Inverted provisional strategy can be used also for many reasons. This is an original one. This patient has unstable angina, a single big diagonal, so relevant. He was double wires, was stented from proximal main to side branch. A very important point here is you have to select properly your stent because you have the 2 diameters are much more different than between the proximal main and the distal main. So take care of the choice of stent. Deployment of stent. Of course, here, don't forget pot. If you forget pot, it will be a catastrophe. You will cross through the stent struts to exchange your wire towards the distal main. Kissing, of course, you see very clearly the difference in diameters, and nothing on the LED. With this result, you will maybe say this is dangerous, but three years later, the result is still very good. So when you have, in another situation, is mini inverted culotte I described already, but the decay crush. Decay crush is, for example, to stent difficult access circumflex with a very long stent at 48. We have seen that in China. It's not really frequent in Europe. So you have this decay crush technique, which is complex, 9 steps. I remove some of them here, and all of them are very important. 2 are being added by Xiaolian Chen. The first is when you crush the stent in the side branch, you have to crush with a balloon adapted to the proximal main. And here, I mean, like a pot. That's the first point. The second point, when you stent toward the side branch, you put your stent in the side branch, with a long stent, you have to minimize the protrusion. If you don't do that, the curve of the stent will leave unstented segment at the ostium of at the carena inside the side branch. And during wire exchange, you can enter in the unstented segment, you do a kiss, and you recrush the side branch stent on the wall. So 1 versus 2, what are the proof of provisional being better? 1 versus 2 stent randomized trial, a lot of them. So you persisted to do a trial, and trial. And at the end, none of these trials showed a difference in death or in cardiac death. So 1 versus 2 for non-left main, this is clear. If there is no advantage to put a double stenting if you can put only 1. When we look at the meta-analysis, this one is relatively old. TVR, 1 versus 2, equivalence of all this randomized trial. But when you move to myocardial infarction, you see that myocardial infarction post-stenting is much more frequent in double stenting than in single. And when you use this more recent meta-analysis, true bifurcation subgroup of early definite stent thrombosis, you can see on both sides, early stent thrombosis is less frequent in the single procedure, intention to treat. Analysis as treated, exactly the same. A significant difference for acute stent thrombosis, early definite stent thrombosis, definite diagnosed by coronary angiography, more frequently in double stenting. And remember, this is not a study on bifurcation. This is a desert trial showing that the major predictor for stent thrombosis is overlapping of stent. So reducing overlapping inside the bifurcation, like decay crush, or outside the bifurcation, is a factor of reduction of stent thrombosis. Decay crush 2, so non-left main bifurcation, decay crush 2. A long time ago now, 2011, you see that it's a randomized trial from Dr. Chen. The TLR rate in decay group is 1.1%, in provisional stenting group 3.2%. The cabbage, this is for the first 6 months. So this is not significant, as you can see. But at 12 months, you have TLR, which is 4.3 in decay crush group versus 13% in provisional stenting group. And this is for the stent thrombosis, on the contrary, there are more stent thrombosis in decay crush. And you have to look at the bottom. In this study, where the endpoint was at 1 year, a systematic coronary angiography was done at 8 months. So the same phenomenon I described earlier. You do an angiography before an endpoint, you find a restenosis or a carena shift, you treat it, and this is more TLR. So this is a mistake in the conception of this trial. Very quickly for left main, because we looked at that, again, this analysis of Excel showed that when you can do a single stenting, do a single stenting. There is no situation where double stenting is better than single stenting. we have seen that already. And decay crush, I showed that already, so I won't insist again. The same phenomenon, this one. No, this one. I think I repeat the same phenomenon here for the left main. If you do a study with an endpoint, clinical endpoint at 1 year, and you do the coronary angiography at 11 months, then you are generating, you see pictures. This is oculostenotic reflex. You see pictures showing a carina shift, a lesion that you even don't measure. You restent it, you retreat it, and you have the result of this trial. EBC men, we skip that. Here, no difference between a simple and double trial, and double stenting. I have to remember you that this trial was done in true bifurcation lesions, so not in a single vessel disease. And you can see at 1 year, there is no difference. Remember the slide of Patrick Sorois? We will be back in 10 years, we'll see. And these pictures on flow, I think they are very interesting. You see a double stenting with only one stent layer at the carina and no overlap at all. You have a perfect flow. And if you look at crush stent, you have several struts at the carina. You have recirculating flow on the normally a segment submitted to high velocity, and you have these turbulences. So yes, provisional stenting is still the gold standard. And I repeat what Goran said, that if you have very experienced high volume operators and you are performing frequently decay crush, you can use decay crush, of course, if you are a specialist. But this is a complex technique, like is a culotte also. Thank you very much.
Thank you, Yves. So, in summary, one by one from the panelists, what should be the take-home messages from this session? I would start with Yoshi, then Goran, and Yves. So, Yoshi, what should be the take-home messages from this session?
Provisional approach is the best for the bifurcation intervention, and the two-stent technique. Technique is the limited the property the lesion for such kind of lesion. It's okay.
Oh, Goran?
But there is no much to repeat again. I said it several times. We don't need to prejudge in advance what is the number of stents. We actually try to step by step go increasing the level of complexity according to the response of the vessel to implantation of the first stent. If possible, we should try to reproduce the anatomy, which is the key, and then decide whether or not we need the second stent. If we need, we should not be afraid to put second stent, and especially for lesions with very difficult wiring of the side branch. If you spend 25 minutes to wire the side branch, of course, this is one of situations in which I can think of planning treatment of the side branch with stenting again.
I don't know what to add to this, of course. I explained already that my practice was nearly always, I think during the recent years, was nearly always a provisional strategy, even in the most complex lesions. So this is the same remark as for Dr. Chen, performing probably several decay crush a week, and myself performing a high volume of complex provisional stenting technique. So it's also related to the experience and the volume of the operator. If you do any of this complex technique 3 times a year, you need the menu on the wall. You don't remember, you know.
Yes. So we have to arrange a randomized study between the best operators in best techniques. So decay crush versus provisional, that will be
center-
Shaoliang Chen versus Louvard.
Center versus center will, you know, this is very difficult because another part of the equation is the patient.
Patient.
And I have visited many times Dr. Chen in China, and I have seen how complex are the patients there.
Yeah.
So they are different patients, completely different patients. So the last point, maybe we can tell that in Europe, probably in Japan also, that provisional strategy is well adapted of the patient you see every day. Yeah.
Okay, so thank you everybody for participating in this session.